for coming. I'm Alex Reynolds. I'm one of the neurocritical care attendings, and I am lucky to be able to introduce today Dr. Cara Melmed. She is a neurointensivist and an assistant professor of neurology and neurosurgery at NYU Grossman School of Medicine. She completed her neurology residency at Cedars-Sinai, where she served as chief resident. And she completed her fellowship training with me at New York Presbyterian Columbia and Cornell, where she was my junior fellow. Her research interests include assessing how social determinants of health affect the quality of care for patients with ischemic and hemorrhagic stroke, and she has spoken nationally on the topic. She is currently working on several quality improvement projects in the realm of diversity, equity, and inclusion, as well as accessibility. She serves on the DEI committee for the Department of Neurology for Clinical Care and Health Equity and the Quality Committee of the Neurocritical Care Society. And on a personal level, Cara was my favorite person to reflect and discuss challenges with. Don't tell the others. She's very thoughtful, as you'll see, and she strongly believes in her values and cares about social justice. So I'm really excited for you to hear her speak today.
Thank you so much for that introduction, Dr. Reynolds, and for the invitation to be here. Today, I will be talking on the contribution of health disparities and quality improvement efforts. And I have nothing to disclose, but I will say that these slides were prepared in collaboration with the quality improvement section with specific contributions from Casey Olm-Shipman, Stacy Williams, Sarah Livesay, and Abhijit Lele. So today I'd like to review and discuss socioeconomic factors that challenge quality and safety. We'll identify health disparities in critical care and understand the potential for bias in critical care delivery and quality improvement measures, and discuss how to improve health disparities through quality improvement using tools to promote health equity and by constructing value-based frameworks that include patient and family reported outcomes, and understand how system level changes can improve health equity, such as using high reliability organizations. So health differences are linked with social, economic, and environmental disadvantages. These are preventable differences that are experienced by socially disadvantaged populations. And although they're often viewed through the lens of race and ethnicity, they occur across a broad range of dimensions, including socioeconomic status, age, weight, geography, language, gender, disability status, citizen status, sexual identity, and orientation. This is an example of age-adjusted health care disparities, an age-adjusted death rate for stroke specifically. So we see that although there's been improvement in mortality over time for patients experiencing stroke, that there's still a large gap between non-Hispanic Black males and females compared to non-Hispanic white males, females, and Hispanic males and females. So there's an opportunity to close the gap here. We think of health equity as that closure of the gap. So when individuals achieve their highest level of health through the elimination of disparities in health and healthcare, this requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequities, historical and contemporary injustices, and healthcare disparities. There are many factors that affect health outcomes in patients that are in the critical care unit, specifically in the neurocritical care unit. So the ICU environments, the brain dysfunction, medications that they get. But social determinants of health are also being more and more considered to affect health outcomes. These are the conditions in which patients are born, where they grow up, where they work, where they live. And these are also inclusive of economic policies and systems. Health behaviors and social and economic factors are the primary drivers of health outcomes, as we're learning. And these social and economic factors shape the individual's health behavior and health outcomes. Importantly, racism negatively affects mental and physical health, both directly and by creating inequities across social determinants of health. So this is an example of how racism can interplay with social determinants of health or geography of where one lives and health outcomes. This is, again, another map of stroke mortality for the years 2011 to 2013. And we see an increased mortality in what's considered to be the stroke belt in the Southeast. But now compare this to county level slave population density in the year 1860. In this study, county level slavery was strongly associated with increased stroke mortality in all races. So just by geography alone of living in a county where there was a high slave population density in the year 1860 led to worse mortality for stroke. There are countless examples in critical care of how socioeconomic status can affect 30-day mortality. This was a meta-analysis of patients, any adult patient admitted to the critical care unit who had any exposure element of education or socioeconomic status that was compared in the literature. And in this meta-analysis, it was identified that indeed lower socioeconomic status was associated with worse health outcomes and 30-day mortality. In neurocritical care, there are many specific examples where, for example, Black and Hispanic individuals have earlier onset and higher mortality from ICH, where social determinants of health, specifically education, mediates the association between race and ethnicity and worsening biomarkers of ICH. A study that looked at multiple social determinants of health, and the more social determinants of health that were associated with the lower socioeconomic status was associated with the higher stroke risk in older patients. And then another study looking at dual eligible patients that had higher subarachnoid severity scores and worse outcomes. Dual eligible patients, those patients that are eligible for both Medicare and Medicaid, are a specifically vulnerable group. So when we think about these racial and ethnic disparities, we have to think about it from many different levels. At the patient level, there's minority patient mistrust, there's experiences of discrimination on the patient level, there's treatment adherence issues, there's health literacy issues. From a provider level, we think of problems with provider prejudice, unconscious bias, lack of cultural competency, and discordance in patient-provider race. At a health system level, there's opportunities for improvement with access to care, quality of care, and then at a policy level, problems with health insurance and resource allocation, and again, structural racism. So we've identified the problem, and now we have to learn about how we can act on these problems. And again, at different levels, we can have different kinds of education, identification, engagement, and policy. At organizational levels, we can think about how our social work and case manager support can help us with critical care programs, focus on addressing social determinants of health and quality and research efforts. And at a societal level, think about how we can partner with our community organizations and healthcare systems and other professional societies at a national and policy level. So quality improvement efforts are being addressed in this domain. There are 6 dimensions of quality improvement: safety, efficacy, patient-centeredness, timeliness, and efficiency. But the 6th dimension of equity has seen less progress. So to improve disparities and ensure healthcare delivery that is equitable, QI measures need to shift from just documenting these problems to implementing change. How do we do this? Traditionally, we've thought of equality and quality improvement projects. And so this idea that a rising tide lifts all ships. The idea that improved care for all improves care for those who experience diversity and disparity. But when we think about quality improvement from an equity focus, we realize that comparing the quality measures amongst groups using high quality real data that's accurate and reliable can improve the quality of care and decrease the gaps. Real data is race, ethnicity, and language data. And again, this must be accurate and reliable. Here's a few examples of research programs that used culturally appropriate interventions and prevention that were aimed at minority race ethnic groups. This was from a group of studies that were all funded by the NINDS in stroke and neurocritical care. So there was a study that was done in Florida by Ralph Sacco and his team using the Florida Stroke Registry. So they were able to implement a statewide stroke registry using our Get With The Guidelines database to identify disparities and develop, demonstrate, and disseminate information about how to improve care at the community level, at the healthcare system level for all of the hospitals involved, and then actually change policy in Florida and in Puerto Rico. This was an example of a study that was done at UCLA. This was a chronic care model that had a strong community-based component. They wanted to assess walking and stroke knowledge among Latino, Korean, Chinese, and Black seniors. And they found that with community engagement symposiums, there was an improvement in stroke preparedness. It's really engaging and working with the community to provide culturally appropriate interventions for patients. And then a third example of home blood pressure telemonitoring for hypertension improvements in different communities. And this group here at NYU found that individualized, culturally tailored telephone-based nurse care management led to better blood pressure control and ultimately reduced stroke recurrence. So let's talk a little bit more about how to apply the practical steps to apply the lens of equity in QI. This is all from the action program. So this was a program from a couple years ago that focused on how to bring equity into QI. So these practical steps that hopefully that you can use as well. The first step is really establishing a strong infrastructure. So you need the human capital. You need a team with the breadth of roles and expertise, a team that's diverse, that's interdisciplinary. Obviously, you want team members that are knowledgeable in QI. And then very importantly, team members that have cultural understanding of what you're trying to do. A team that doesn't have this kind of knowledge of the target population might be developing interventions that are not culturally relevant and they don't achieve the intended results. You want to involve your stakeholders. So having your leadership support is very key to establishing your infrastructure, engaging your senior leaders, and then really communicating with them to keep them engaged. So communicating early wins, communicating modest improvements, and this keeps the leadership really involved and supportive of your effort. And then you want to make sure that you have appropriate data. So we talked a little bit about this, but healthcare utilization data and performance outcomes is really critical to understand in order to address health equity comprehensively. This data needs to be real data and it needs to be accurate. So again, race, ethnicity, and language data is a really base level to start at. And then of course you want data that's representing social determinants of health. So it's really important to understand that the racial and ethnic data in our EMR is often unintentionally misrepresented, and this can be used inappropriately. So you can't fix what you can't see. You really need to identify your disparity of interest from the beginning based on your data, and then create that infrastructure to build models so that you're collecting accurate and real data. This obviously takes a lot of effort. Okay, so step 2 is rethink your aims. It's important to have equity focused and SMART aims. SMART aims are specific, measurable, attainable, and realistic and timely. You want to know what the barriers are that are leading to the inequities and think about which, for example, which group is affected and set appropriate goals to reduce disparities. We'll talk about goals in a little bit. When you're using your data, you need to be really clear on your measures. Measurement is a critical part of testing and implementing changes. And you can think of 3 different kinds of measures: outcomes measures, process measures, or balancing measures. Outcome measures address the impact of the changes on patients' health and well-being. Process measures assess if the parts or steps in the system are going as planned. And then balancing measures look to see and assess how changes that have been implemented are causing new problems elsewhere in the system. And then you also want to be really clear about how each measure is defined and how it's going to be stratified. Performance measures that take into account the patient-reported outcomes are really felt to be much stronger and have a much greater impact when we're thinking about these kinds of projects. This is because there's a huge potential for bias in neurocritical care and critical care delivery and quality improvement measures. And so we can think about combating this using value-based frameworks that include patient and family reported outcomes. So performance measures look at, for example, this is an example of mortality in stroke. So we see here the hemorrhagic strokes, intracerebral hemorrhage mortality, and subarachnoid hemorrhage mortality. But is this even a measure that has a risk of bias? There are obviously ethical, cultural, social, and individual considerations when considering mortality, particularly, for example, when it comes to limitation or withdrawal of life-sustaining therapies. So you really need to take into account the family beliefs and values and the social, environmental, cultural context in which they exist. And you also have to understand that priorities for patients and their families are going to change over time. Another potential for bias with these measures is that they're adjusted. So here we can see the adjusted factors for mortality and subarachnoid hemorrhage. They're adjusted for age, gender, insurance status, and many other considered covariates and coefficients for risk adjustment models are made. And so obviously, the more that you have, the more potential for bias you find. When you're using risk adjustment, you have to be sure that you're looking at patients in an appropriate fashion and comparing outcomes that are adjusted for differences, but also making sure that you're not using comparison for certain measures without these risk adjustments, and understanding that the risk adjustments themselves are at risk of being biased. There's obviously a gap between collecting and integrating the data. So just having the data doesn't mean that your performance is going to improve. So you have to understand also how to interpret the data. And there's really a lack of a uniform model within the field. So we have to think a lot about this. Something that we think about is equivalency framing. So understanding that the evaluation of the data is really influenced by the context of that information. So this really biases how we think about the data itself. For example, when you change the valence of a particular data point, it really changes the meaning. So think about how saying that the unit has achieved 80% of its targets or the unit failed to achieve 20% of its targets really comes across as a different factor when in fact it's the same. Other factors to consider is how motivated reasoning and choice complexity can be potentials for bias when interpreting operational data. And then also just thinking about the measures themselves. Who's writing the measures? What kind of authorship do we have? Is there diversity of different subspecialties? Is there diversity of ethnicity and race and gender in the groups that are writing these measures? So value-based frameworks are thought to help combat these biases a little bit in neurocritical care delivery and critical care delivery and quality improvement measures. So these focus really on the outcomes that matter most to the patients, and it kind of aligns the care with how patients experience the health. And the idea is that you move towards payment for providers based on the quality of care that the patients are receiving. Value in healthcare is the measured improvement in a person's health outcomes for the cost of achieving that improvement. And the value focuses primarily on improving patient health outcomes. But we know that we have better health outcomes with lowering costs that when you start from a patient level, when you understand the shared health needs of the patients themselves and then design the solution to improve those health outcomes, integrate that with your learning teams, and then expand your partnerships. These are examples of value-based programs that are already in use. So for example, the Hospital Acquired Conditions Reduction Program. So these are all programs in which the hospital is reimbursed. But what we should start thinking about is models for payment reform that address inequities in patient safety and healthcare quality. These exist on some level, but they're only starting to be adopted or consistently implemented. These are some examples of CMS changes that have occurred under the current administration. There's been a real focus and push to really consider health equity and how to award hospitals that are achieving these goals. So the Center for Clinical Standards of Quality have described these goals and the actions that they've done to date. So they've been able to explore the development of health equity focused measures in all care settings. There's now a birthing friendly hospital designation to ensure that there is decreased maternal mortality. That's with the goal of decreasing the inequities in maternal mortality, and then really directing quality improvement resources to populations with the greatest health disparities. So again, these are great, but we really need to focus on what is important on the patient and the family that's providing the care for the patient. Again, is mortality a good patient family-centered measure? Or should we be looking at other questions like, is the patient returning to work? Does the patient have access to inpatient rehabilitation? What are the barriers to inpatient rehabilitation? Is there caregiver training prior to discharge? So really, are we asking, does it matter to the patient and to the family? These are examples of patient-centered outcomes that we might think about when creating our measures of what really matters to the patient. So healthcare delivery, access to care, perceived benefit, ease of care navigation. These are all really important measures. This is an example of the burden of family caregivers, which I think has a huge deal for our critical care patients that we're discharging home, and they're being provided, the care is being provided by their family. So what kind of burden are these family caregivers having to deal with? Another few candidate measures are listed here. So again, caregiver training, outcome metrics like return to work, inpatient resource utilization, communication in preferred languages when the patients are inpatient. We've seen that patients that are communicated with in their preferred language actually have shorter length of stay. Do the patients have access to outpatient services? Are there prognostication scores that account for resources? What kinds of patients are using hospice? These are some specific quality measures for equity outcomes to consider. The development and use of quality measures that can track performance along equity outcomes and help establish monitoring systems in which processes and outcomes of care can be compared by patient rates. Stratification along demographic and other equity sensitive factors would be sufficient to identify gaps. And so again, making sure that we're really collecting the appropriate data, developing new measures that assess implicit bias and inequitable treatment. These can be part of standardized instruments that we do that might help assess implicit bias and link to behavioral change interventions. And then we can use this data to self-assess, monitor, and evaluate the effectiveness of strategies for eradicating inequities, and then give critical care units or individual clinicians appropriate targeted feedback. And then when inequities are found, support creative solutions for remediation and create accountability, and then have standardized population level measures of disparities and outcomes tied to both social determinants and bias. So, okay, so for our action steps, step 4, you really need to tailor improvement strategies in response to health beliefs and cultural norms, as we've spoken about a little bit. System level changes are one of the most important. So system level changes can be the primary intervention or it just might play a supporting role. Clinician and staff need to be trained, and then the changes need to be tested. So 2 examples that I want to talk about system level changes. The first is integrating social care into the delivery of healthcare. So how can we use our social workers in the hospital to really engage with the patient, engage with the family, and understand how to identify their comprehensive needs assessment, and then deliver culturally appropriate interventions for our patients, regardless of what the measure might be. Another example of system level change is this idea, this cultural change of into a high reliability organization. So a high reliability organization is an organization that succeeds in avoiding catastrophes in an environment where normal accidents are expected. So think of aviation, hospitals, nuclear power plants. You can transition into a healthcare organization that is focused on high reliability with these 3 steps these were outlined by the Joint Commission. So first of all, you need a leadership commitment to zero harm goals. The goal should not be better, the goal should be zero harm. There needs to be a safety culture embedded throughout, and then there needs to be a robust process improvement program, such as Lean, Six Sigma, or the Improvement method. So we think about target goals as reachable, but in this high reliability organization and culture, we think about zero harm. So we need to promote unconventional thinking, innovative ideas, and novel strategies to make big gains in quality outcomes. And when I say harm, we think about, as doctors and clinicians, we think about wrong site surgery and hospital-acquired complications, but we really need to expand our understanding of harm to include inequities. So harm is access to care, barriers to care, language or geographic impediments to care, the timeliness of care that's being provided to patients, and the socioeconomic impact as well. We should really strive for this culture of safety. This comes from a high level of event reporting. We should really promote event reporting. This should not be punitive. It should just be part of the culture of understanding that with an increased recognition of health disparities, we have an opportunity to improve when there's suboptimal care. And this starts from the leadership and goes down, and it really needs to be an active effort to change the culture. And then these are some examples of robust process improvements. So for example, the Six Sigma, this measures and reduces variability in our processes in order to approach consistency in our system outcomes. You can use the improvement method. Here we apply small tests of change to adapt and improve processes and outcomes. So these are just different examples. Step 5, we want to sustain and spread. So you have to plan for sustaining improvements and spreading effective changes throughout the system. This requires a leadership support. It requires engaging physician champions and representatives from all levels of staff. And it really requires putting the necessary infrastructure into place. And you have to keep in mind that what works for one doesn't work for everything. So the changes that you make, you need to tailor again and continue to assess and make changes. And remember to continually ask, are we learning something about these patients? So you want to plan from the beginning for sustained improvement. Continued focus on reducing disparities requires designing and implementing the quality improvement measures that directly address health care equity. So within neurocritical care, at least, we have ample room to apply this to improve our healthcare delivery. And if we just focus on equality, if we just focus on this one-size-fits-all methodology, we might worsen the disparity gap. So using quality improvement study and design requires proper engagement, data utilization, and appropriate study design and active learning. And again, it must be sustainable and capable of spreading for effective change. So in summary, we talked about the socioeconomic factors that challenge quality and safety. We hopefully identified some of the healthcare disparities in critical care and now understand a little bit more about the potential for bias in critical care delivery. We talked about how to improve disparities through quality improvement using tools to promote health equity and constructing value-based frameworks that include patient and family reported outcomes. We understand how system level changes can improve health equity, such as through high reliability organizations. Again, thank you to my healthcare QI mentors and equity mentors. And I'm happy to have a discussion and take any questions.
Thank you, Dr. Melamed. I'm sure people are going to be asking some questions in the chat or in the Q&A, but I think I'll start with, I think this was a beautiful framework of how to approach practically identifying and then sort of initiating ways of tracking and improving outcomes. I wonder, it feels like really, really big. And so I wonder if you have been doing anything at NYU to sort of start initiating this and how you coordinated with hospital leadership or unit leadership or department leadership to sort of start this ball rolling.
Yeah, that's a really important question. So a few different answers. So it is big. There's a lot of theory here, but I think that when you sit down to design your quality improvement project, I think when you're trying to even base it on equity and eradicating inequity, I think you realize that, or I realize that really all quality improvement has this goal. So improving care includes narrowing that gap. So many of our quality improvement projects are really going to have an equity focus as a sub-aim or as the primary aim. So keep that in mind when thinking about anywhere that you see an opportunity for improvement in the hospital, that it's probably going to affect many different kinds of people and different kinds of patients in different ways. I think with neurocritical care, or with critical care in general, and thinking about social determinants of health, it's really important to see the system and the path of how patients come from a community, experience their illness, and end up in the ICU. And so where along that point can we intervene? Really, we should be really intervening in the community. And so even though we're thinking of how to affect change in the critical care unit, we really have to affect change in the community. And so what do I mean by that? So one example is language. I think this is a big issue in stroke care and stroke care delivery, is to recognize that patients who have language barriers, or who don't speak English, or who need interpreter use, they have delays in care. And we looked at our hospitals at NYU in both Brooklyn and Manhattan. So we have a lot of patients who speak Russian, a high proportion of patients who speak different dialects of Chinese. And in these patients, not only did we see that there was delayed care in patients who were requiring interpreter use, so we defined that as access to TPA, so intervention in the emergency room, but there was also a delayed recognition of, well, there was a delay to getting to the hospital. So is that delay getting to the hospital, is that recognition of stroke symptoms? Is that because they don't know how to access EMS services? Is that because any variety of factors that might be contributing to that pre-hospital delay? And that pre-hospital delay is going to affect if and when they get their TPA, and that's going to affect their long-term outcomes and their experience in the neuro ICU. So creating an intervention that will affect the community can really have an effect in the ICU itself. And there are many examples of interventions that have been done in the community. I described one that was done at NYU with the walk study, where patients were able to learn how to identify their strokes earlier. There's other examples from New York using the hip hop stroke videos, so communicating to different communities how to recognize stroke. So there are ways to actively engage the community that we know and we've seen has worked. Once we get to the hospital, there are specific QI projects that have been successful. The one that I mentioned was using three-way interpreter phones. So just having that ability to have the three-way interpreter phone when the patient's on the phone, the interpreter's on the phone, and the provider is on the phone. Everyone has their own phone in the room, so that really is limiting the need to wait for an interpreter to arrive. And not only was care delivered in a faster manner, but in that study, patients actually, like I said, had a shorter length of stay. So how to engage the leadership? I think that this is a really important topic right now. I showed you some of the CMS changes that are going on right now, and there's a real drive for payment and for reimbursement to be associated, for hospitals to be able to show their equity efforts. And so I think right now more than ever, hospital leadership is really interested in engaging in this kind of work and are happy to support it. So I've had the fortune of being able to communicate directly with my leadership. I think just because people are so interested in it and want to show, here's what we're doing as a hospital. So we've identified the problems. I think that we all know that these problems exist, but here's what our hospital is actively doing. And look, here's what Cara Melmet is doing to make these changes. And so I'm going to support Dr. Melmet and her efforts because it's going to support my hospital as a system. And so when we see those kinds of changes from a policy standpoint, from a presidential and CMS standpoint, then that's when it's just easier to engage the leadership to support these kinds of projects.
There are questions in the Q&A. I don't know if you want to read them out and then answer them, or if you want me to read them while you think.
Sure. So I'm thinking and reading them at the same time. So
Okay, I'll ask them because you won't say things like, thanks, Dr. Melmed, really great talk. So this is from Dr. Dengayich. How do you balance the time needed to deliver care, document, teach, do research, and other responsibilities with these newer initiatives to weave social determinants of health, data collection, implementation of newer QI initiatives?
Thank you for that question. That's the question of balance is a question, a very important one. I think that you just need to prioritize. We all can't do everything. Some of us, like Dr. Dengayich, is better at that than us others, but I think that prioritizing. So this for me is a priority, and I know that it's part of my research efforts. It's part of my interest. So I want to improve outcomes for my ICH patients, and social determinants of health, as I said, are going to affect outcomes. So if I'm going to have any real meaningful impact in my patients, then I need to focus on that kind of research. As for teaching and other responsibilities, I think it's intrinsic to teaching. I think that as for myself, I need to learn and educate myself and better think about my own implicit biases and my own problems. And I need to be able to communicate with my trainees as well in a similar fashion. So I think the balance for everything comes from what you prioritize. And so you make time for it. And then question on how to engage non-physician team members. So I think this is a really important question, and I hopefully addressed it a little bit in my talk, but I think that the non-physician team members are essential to creating these kinds of programs. So particularly working with the social workers, I think this group has a huge potential for creating meaningful change. So understanding really where the patient's coming from, having the time to give the patients and to sit with the patients and to think about these kinds of things. I think that by helping them understand what an important role that they play in the system is, I think that we do a really good job of reminding our nurses how essential they are to the care and treatment of our patients. And I think we need to be just as good at reminding so we as physicians and as maybe the leaders in our units, identifying the important role and really accolading them and giving them the credit that they deserve and really making and implementing these changes and making them understand how essential they are, and so that they see their role as essential as it is, and engaging them in that way.
I was personally texted a question that I'll ask you, which is there any way to sort of, you talked about engaging the community for sort of outside of the ICU care. Is there a way to engage the community inside the hospital, getting community leaders to sort of give you feedback on the initiatives that are occurring in your unit?
So I think a big initiative and where we can really use our community providers is, for example, in the idea of creating do not resuscitate and withdrawal of life-sustaining therapies. So this is something that is heavily, there's a lot of differences in patients who have different cultural and religious backgrounds. And so engaging with the community to really understand what the patient's values and goals are. This is not something that we can do alone as doctors siphoned in the critical care unit. We really have to use our community and our community liaisons to be able to think about, especially for patients who can't communicate for themselves, what are their values, what is important to them, how is end of life going to be meaningful, and how can we create a peaceful process for the patients. Also thinking about things just as simple as different dietary needs of patients. So there was another study, for example, of patients who whose dietary needs were met in the hospital had shorter length of stay. So that's super interesting to me that something as simple as that can really affect their hospital length of stay, and being able to again turn around to the administrators to say it's this easy to affect the change that you're trying to see. So we need to use our community liaisons to understand what things like that besides food can we create an environment for our patients that leads to healing and recovery.
Are there any other questions from the group? I'll say that I really appreciated your talk. I think the amount of data that you presented, the evidence that you have to really support this is helpful in sort of going back and making your arguments to whoever it is you need buy-in from about this sort of stuff. I think sometimes it can be challenging to get the buy-in that you feel that you need for certain initiatives. And it's great to see how much you've really invested in this as someone who's always kind of been interested in social justice. So thank you so much for your insight.
Yeah, thank you for the opportunity again to be able to present this. I think it's like I said, more and more hospitals and more administrators are interested in this kind of data and in this kind of work. And so I think that if you're interested in it, you'll find that it's actually something that you're going to get support in doing, hopefully, and being able to convince your administration why it's important is something that hopefully should be an easy conversation. And if it's not, I think really examining why would the administration be resistant to this kind of work, and what kind of implicit bias and changes need to happen at an administrative level, and maybe pointing that out as well to the administration.
Just want to make sure there are no other lingering questions. Great. Thank you so much, Dr. Malmed.
Thank you so much, Dr. Emil.